This is Pod Populi.
Podcast for the people.
Hi, this is Pamela Worth with the Encourager Wellness Podcast, and today I have Dr. Paul Anderson. He's a recognized educator and clinician in integrative and naturopathic medicine with a focus on complex chronic illness and cancer. In addition to 3 decades of clinical experience, he was also head of the interventional arm of the US-NIH funded human research trial using IV and integrative therapies in cancer patients, which is just awesome. He founded Advanced Medical Therapies in Seattle, Washington, a clinic focused on cancer and chronic diseases, and now focuses his time in collaboration with clinics and hospitals in the US and in other countries. Thank you so much, Doctor, for being here.
Thanks for having me.
So, where do you want to get started in this? You've done so much. When people think about chronic disease and think about cancer, when they come to you and say, I don't know what to do next, how do you like to get started in this journey of kind of unpeeling the onion, if you will?
Well, that is a great place to start. I think that if I think a good place to start is where there's similarities, because obviously, if I have a non-cancer chronic illness, I don't think of myself obviously having cancer. If I have cancer, I might think of it as a chronic illness, or I might think of it as its own entity. But one of the reasons that my practice started this way, but I kept it this way over time, was pretty close to half oncology cancer patients and half complex chronic illness patients. And sometimes it's more of one or the other, but that's basically it. But other than the fact that I didn't want to get too over specialized, which happened anyway. But I look at the sort of holistic or integrative approach to each of those groups of problems very similarly. Now, when we get down to specific things, there might be a lot of differences or some differences, et cetera. But when you start out, the first thing is, where is the person, on their journey with whatever illness group they have? And you interact often very differently with somebody, for example, who is just diagnosed with a autoimmune condition or a complex chronic illness, but they're very much on the front end of the journey. Or you might interact very differently, for example, with somebody diagnosed with a very, low stage, low grade treatable cancer that, is going to go one way with treatment, versus maybe on the chronic illness side, somebody who's 10 years in with no great answers, and their case just gets more layers to it and more complicated. Similar approach there to actually somebody who has a stage 3 or 4 cancer. It's gone in multiple places in their body, and you have a lot of other things to kind of juggle and approach. So while the entities may be different, what makes us healthy or have a lack of health, there's a theme that runs through all of it. So approach wise, the first thing is, if the patient hopefully is in front of you, or maybe electronically in front of you nowadays, where do you meet them? What do they want out of what we're going to do together? But also, what have they had a lot of really good treatment and they just need little tune-ups, or are they new to this and they really don't have much much to go on?
Doctor, we can't hear you all of a sudden.
Oh, okay.
Okay, you're back.
Okay.
You were talking with your hands.
Oh, well, how long? It depends how long I was talking, whether it was good or not. So I'll back up a couple sentences maybe. So just depending on where you meet that person, that predicates how much and how broad and how many areas we look in, as I say, are the places where we can either hold better health or get sick in those areas. And we can talk about the main areas that we see, but that's kind of the top-down approach that I like to use. And it's a melding of a lot of years of doing this and then what do you want and need? And if those can come together, it's, then we get specific.
Yeah, I like what you're saying about wanting to understand where the patient wants to end up. So, what is their goal? And then from there, do you have a certain protocol that you like to follow? Do you have a certain group of lab tests or certain types of markers that you're watching first to determine the severity of where it is? And then is there certain things that you like to touch on first around detox or nutrition or anything else that you kind of like to put in the beginning, middle, and end?
Hmm. Yeah, so once you have that kind of meeting of the minds, hopefully, and you develop a big picture plan, then the next level of granularity is defining where is your body at with the process. And so in the world of cancer, I'll use that because it's believe it or not, a little bit more linear than a complex chronic illness pathway. There's basically 4 phases that a human goes through with cancer. And so the next thing that I do once we come to this kind of, mind agreeing on what we want to do is to say, are you in, phase 1, 2, 3, or 4? And this doesn't necessarily have to do with the staging and grading, which is more of pathology. But the 4 phases are primary prevention, which is most people who don't have cancer. We all make cancer cells every day. Many people who have cancer don't know it yet. This is the time where you have like a lot of options because you're trying to prevent something. And so I always tell people, 20 to 30 years ago, nobody came to see me for primary prevention. It was just not a thing. I'm sure it was a thing somewhere, but nobody came to me for that. But it mirrors the 4th phase, which is secondary prevention. We'll talk about in a second. In that, your whole goal is to make yourself a tiny target for cancer, right? And to live as long and as healthily as you can. But let's say you miss that window. Where a lot of people come to us is in the first active portion, so phase 2, which is their diagnosis through their active treatment. So biopsy, imaging, maybe chemotherapy, radiation, surgery, or maybe that's not appropriate and they're told you have this cancer, but there's not a good treatment for you, or you're too weak for the treatment, which we hear sometimes. So if they're in that phase, what you can see is we have a million things we possibly can do at every phase, but allocating time and resources is very important. And if my body is trying to deal with cancer and I just got diagnosed and I've been through a surgery for, biopsy purposes, or getting all this imaging or whatever I'm doing, I may only have so much time and to do other things, and also energy and finances, right? So if that's in that phase, diagnosis through active therapy, what I'll tell people is there's lots of things that we want to start doing, but we might wait till you're done with some of these big heavy things before we start them. Because what I want to do, and just for the sake of the discussion, this doesn't mean it goes this way all the time, but let's say a classic case: person diagnosed, they've got all the imaging, biopsies, whatever they did, and they come to me 2 weeks into chemotherapy cycle and they say, I'm doing this chemo or this radiation, whatever. That's really common because they'll say, well, I've heard I can make myself healthy through this, et cetera. And I would say, yes, that's exactly our focus. So my discussion with them would be, I want to use your time, your energy, and your resources really wisely here. I want to use them wisely always, but what that means is I can do things to help you with your standard treatments, whatever they might be, so that they work well, but they don't hurt your normal tissues and you recover well on the other side. And so that's where our focus has to be here. So it's a little more narrow, but then that allows us, should all go well here, it allows us a healthier you on the other side, and then we can broaden out our scope, right? And what a lot of people don't realize, but it's becoming a little more talked about now, is so I'm going to say this is one of those things that has a dark side and a light side to it. So I'm going to give the dark side first. Um, it's been in the research for over a decade. And one of the books that a colleague and I wrote about cancer for patients was the first book to publish it in a book form, because we published the dark side, which is chemotherapy and radiation are really good at knocking down your initial tumor burden, which is great. That's fine. They're also really good later on of making stronger cancer stem cells so
Right.
that either a new cancer comes back or something like that.
Right.
So that's the dark side of it. But here's the thing. If you look at that, that is all based on a system that doesn't do anything else for you.
Right.
I mean, obviously, if you get an infection, they'll treat your infection or whatever, but they're not looking at you, traditionally holistically. They're not looking at keeping your healthy cells really healthy and keeping the cancer stem cells from getting too
Yeah.
strong.
So this is where I want to ask you about a couple of things.
Yeah.
One, IV therapy, because when my mother was going through cancer, uh, a very well nationally known and internationally known entity had told her not to do that because it would interfere with the chemo. And I told her to quietly do it on the side anyway, because I said, you can't kill every cell in your body and expect to be okay at the end. So, she heeded some of my advice on that one. So I'd love to kind of hear a little bit about the types of things that you really love doing in IVs. There's lots of controversial ideas around B17 and vitamin C and things that some people believe are helpful, some people, don't believe are helpful. Um, and then I would also love to touch on when people use the word immunotherapy,
Hmm?
it's not the same word everywhere. And
No.
so would love to kind of touch with you on
Yeah.
both of those.
Yeah. So it's a good segue. So trying to go from the dark side of that whole, chemo and radiation thing to what would we do to make it the light side. One of the things, if somebody can do it, that and keep in mind, I've been doing this a long time, and I I continue to do things that show a track record of being helpful, and I kind of let go by the wayside things I maybe used to do, but it's like let's focus on the maybe things with a higher value. If somebody can do it and they come into me, even if they just got their biopsies done or they're going to start chemo or radiation, whatever, if I can do intravenous therapy with them through that time and I time it appropriately, what I have seen over and over and over again, and what more and more research is showing, that gets published, is that that person stays healthier through the process of whatever treatment they're doing. And the way the tumor biology works with this cancer stem cell becoming stronger and stronger idea, you make that less of an issue. You can't make it go away, but you make it less of an issue. And so, yes, if it's possible for the person to do intravenous therapy, so people might say, well, okay, let's say all things being equal, why would you prefer intravenous therapies there over just doing a lot of oral therapies, for example, or whatever? So, which I'm not opposed to. The reason certain intravenous therapies probably make that window of diagnosis and treatment work better is you're kind of meeting the intensity of the other treatments kind of on a level playing field. There are things that I can do if I can put, say, vitamin C intravenously into you that it can't do orally. There's a big difference. There are some things that just aren't going to work orally very well, or their toxicity maybe is a little too high. The other thing, though, is you may not feel real wonderful when you're going through radiation and or chemo. And so I might have to be very careful how much we give you that to take orally. You may have intention of taking more, but you may just feel so badly you can't do it. So an IV is a way around that. Now, the the focus during that time is truly on making the rest of the body as protected as possible. But the side benefit, and we used to only know the part one, which is make your healthy cells strong. The side benefit of doing that is the tumor bed, the tumor milieu where it lives, and the cancer stem cells are less likely to get real resistant and become an entity unto themselves if we do that. And so by doing IV therapy in particular ways during that time, we can do it. And the way I talk to a patient is I'll just say, you have a lot more cells that don't have cancer than do. Okay. Now, obviously, we care about the ones that do have cancer. We want to beat them up. But I care as much or more about your healthy cells because that's what we want to keep healthy. Length of life in cancer and quality of life are directly related to the healthy cells and how they're working, really. And most people, that kind of makes logical sense, I think. So to be specific about therapies, if I only had one therapy to do during that time where they're getting active treatment or recovering from surgery, et cetera, it probably would be high dose vitamin C, which is the number one well-known kind of, IV in cancer outside of chemo. Now, you bring up a good point, which I think because people hear 11 million things, and as soon as they go to, I would say in North America, 9.5 out of 10 oncology centers will tell them don't do any of that because it's going to interfere with, the chemotherapy or the radiation or something. That research I was talking to you about before, or that you actually mentioned, was funded by the National Institute of Health here in the US. And one of the parts, so I did anything that invaded a person in interventional parts. So IVs, injections, all of that stuff, but we did everything. We were partnered in a big group through the University of Washington and the Seattle Cancer Care Alliance, which is huge and very famous, and some other entities. And so I had to, in the beginning, answer the question literally every day to our medical and radiation oncology colleagues of, wait a minute, we don't think vitamin C IV is a good idea because won't it get in the way of our chemotherapy, for example? And I've been answering that question for a long time before, but what I started to do and what exists now is a resource that I put together for the oncologist, and it went through all of the major types of chemotherapy and what research there is with vitamin C. And I never had an oncologist, even now, all these years later, who was not surprised, number one, that there was any research at all. And number two, the big shock was it wasn't what they thought. It was actually positive. It showed synergy or something good, right? And and keep in mind this is a research summary, so it's very there's a lot in there. It's over 30 pages long. I would send them the parts germane to whatever chemo patient was getting, and normally it was like, oh, this is all positive. So there's only two responses to that. One, the one I liked better, was didn't know there was research, didn't know it was positive. Yeah, great, we can be friends, and I'll refer more patients to you. The other was more just, well, okay, that's fine, but I don't like what you're doing, or some emotional thing that was like, well, whatever. So that really did help. Now, it was interesting because we had a lot of patients who were employees of the University of Washington, PhDs, MDs, things, and their doctors would push back, and they would go back with the research summary and directly fight the doctor, and they would give in. Otherwise, I was doing it. So generally speaking, it's not what people think. It's not going to magically make all that chemo not work. I mean, if there was actually an agent that could do that, and there's a few that are used in research, it would work very differently than vitamin C does. But here's the other cool thing. The way that happens, if you give someone, conversely, if I give you a platinum chemotherapy or a taxane or some standard, tumor killing one, it's going to hurt your normal cells and it's going to hurt your cancer cells. Can't go away with it. If I give you high dose vitamin C, your normal cells have enzymes to use it just as an antioxidant, even though it's a pro-oxidant when it goes in. So they get a nice vitamin C treatment. Your cancer cells mostly lack those enzymes, and so it creates an immune response against the cancer cells. So it literally goes in and does two totally different things depending on who the cell is, right? So that's why I really like that therapy. It's not that I use many things, but if somebody says I can come in one time a week, I've got this one day I'll devote to this or two or whatever. Sure, I'm going to do some dietary advice, do some other advice, but I'm going to say let's through this window, let's maybe focus on high dose vitamin C. And the other thing is people come out the other end and they're healthier. So then all the other phases we go through with cancer, the third and the fourth phase, are easier to deal with because they're not so wrecked, right? And, kind of like I think it sounded like you told your mother, and I'd probably still do this, but especially in the earlier days, I would just tell patients, look, it's still your body. Here's the facts. You get to decide what goes in your body or not. If your oncologist is just going to have this giant emotional problem about it, then it's up to you whether you want to tell them or not, because this is not their area of expertise, by the way. Like I don't dose the platinum drugs for them, and they don't get to do this for me, right? And now it's a little bit easier, but in the olden days, they would literally fire patients for getting, anything from me. So yeah, so it's one of those things, but that's not to say that's the only thing you do, and it's the only, but it's like to get that much benefit from like one treatment a week or maybe two.
Yeah, it's quality of life.
Any other thing, it's pretty hard to match up, Now
Yeah.
you get done with chemo and we're in the recovery phase, you're not feeling quite so bad. There's a lot more oral things that we can do, a lot more detox things. We do a lot of other stuff. Yeah. Yeah.
Yeah. Okay. Immunotherapy. When
Yes.
when some entities say they do immunotherapy, it's not
Right.
actually immunotherapy. So maybe you could just kind of touch on what is immunotherapy, how it's interpreted and potentially used.
Yeah. So the the way that the way that especially North American oncology uses the term immunotherapy, and the reason they can use it the way they do is it's so broad of a term it could include almost anything. Okay. But what people need to kind of step back from and see is, and it's changing a little in North America, but very slowly, is in the North American oncology mind, an immunotherapy is really more of a biologic drug therapy. Okay. Targeted therapy, they call it, which sounds a lot cooler than biologic drug. Uh, Biologic drugs, which are used in autoimmune conditions, cancer, and a few other things, are the largest money producing part of pharma. Okay. It's over $3 billion a year or way more. Now, it's also the biggest, one of the biggest areas of growth of new drugs that are being produced, because the upside financially for pharma is huge. And if they find one that actually works, the therapeutic upside can be huge. But here's the contrast that I think you're getting at. That is an immunotherapy often because it like targets this one little piece of the immune system and either turns it on or turns it off, right? Now, our immune systems are so complex, sometimes turning one piece on or off can get a little dicey. Okay, so that's a whole other thing. But then there's immunotherapy, such as a lot of the autologous immunotherapies, meaning they would take my tumor and build a dendritic cell therapy or natural killer cell or some other subtype cell, and say, we don't just want you to be, against that tumor in general. We want you to be against this particular tumor with all of its markers, right? And in a lot of the work I've done outside the US, in big universities tied to big hospitals where they do this, that is really the frontier where I see more benefit happening, especially for cancer patients, because you're building their immune system to be more aware of their tumor, which is the reason my tumor got bigger or my cancer got bigger is I was unaware of it immunologically.
And it's personalized.
It's
It
very,
didn't it doesn't come out of a blood bank. It's
it's
your
you.
blood, your
Yeah,
body. It's
it's you. Yeah, which is what we wanted our body to do in the beginning, right? So it's just reacquainting your body there. So you could call both of those things immunotherapies, but one is literally like turning switches on and off, globally speaking. And, sometimes that can help in a piece of cancer therapy. It certainly doesn't cure anything, but it certainly can help. Whereas the other is taking your immune system and training it for your new problem you have that it wasn't, maybe aware of. And something that, because people will say, well, I don't understand. Like I've had my immune system before I knew I had cancer. Isn't it already trained? Because that's how it's supposed to work. Well, one of the reasons cancer develops in people is that many cancer types have immune cloaking devices, literally like, on the old Star Trek, when the cloaking device, you can't see them. They have that biologically that they can produce in the case of many cancers, especially the invasive ones. So your immune system never gets a chance to see it in fully. So what this does, the personalized, human autologous type of cells, is takes your cells, takes your cancer, builds up enough, and then acquaints them with no cloaking, and so they see the whole thing. So, uh, and like everything, I think there's a long way to go of research. It's certainly way different and better than it was 10 years ago, but I see a really big upside in the future. And we're, if you look at North America, they are doing some studies here and there to try and prove concept and get it in the pipeline. Um, but like many things, I wish we were a little bit more aggressive there and maybe put more of our resources there, because
yeah.
I truly think it's got more of an upside than many other things that we do.
Uh, do you, I mean, I have to imagine there's people that come to you that don't want to go through chemo at all. I've had a lot of them contact me um, over time and ask me, what would you do? And I said, well, I mean, I can share, the research that I had done. I was going to take my mom to Europe, and then I ended up taking her to Mexico, and we tried to get her into Panama but couldn't get in. And I mean, there's lots of different potential places. Do you partner with anybody outside of the country? And if you have to be careful answering this question, given your licensing, I completely respect that.
Yeah. So the to the first part, which is, well, what do you do if someone says they don't want to do chemo or radiation or whatever? The in this country, regardless of where else they might go, the conversation I have is a more specific one to the one we talked about in the beginning. And that literally is, and this is how I would think of it personally if it happened to me or my sister or my whoever. Uh, there are pretty well documented published statistics for how well this stage and grade of tumor responds to the standard of care treatments, right? And normally we have like a first line and a second and maybe a third and fourth line. So you can get the statistics on those, right? If you have a cancer that is, 85, 90% plus responsive, like actual 5-year, cures, which there are some, not a lot, but there are some. My personal experience is you would be very ill-advised not to do that, because it's just like take those odds, right? Just go to the other end of the spectrum. And it's getting better in the US. Not everyone will do this for liability reasons, but a lot of oncologists now are saying if you're at the other end of the spectrum, let's say they have a very aggressive pancreatic cancer, oncologists will say, I've got a 4 to 6% 5-year survival. That's 4 to 6%. I have 100% chance of giving you all the side effects. if it was me, I wouldn't take a 4 to 6% thing. The oncologist literally will say, you need to do what you want to do, but I wouldn't do that to myself. Okay. And obviously there's shades in between. But when people say, oh, well, you should, always or never, just don't work with humans because that's not how we work. If you have a really high chance, what I tell people is, okay, take the high numbers, but then let's do all of this other stuff to make you a very tiny target for recurrence. Sure, do that. If you're on the real low end, single digits, low double digits, nobody legitimately is going to say, oh, you should have taken a 4% roll of the dice. And that's the calculus that I try and go through with people. Now, they still get to make up their decision about what they want to do.
Mhm.
And I generally try and support them no matter what. The tougher ones are, what if it's in the middle? Like, then you have to, because here's the thing. Let's say it's a middle, like 50, 60%, 5-year survival. It's, it's above 50%. What I've seen with people is the person that treatment, it's the same with natural stuff, but the person that cancer treatment goes into makes the difference in how well they weather those 50, 60% odds.
Yeah.
Because you can have people who are really sick, their immune systems don't work anymore, they're very beat up, they're likely just to get side effects and they may need some other help.
Yeah.
You got people who go into it who are very robust, have good immune support, and they're doing all these other things to support it. They're more likely to make the best out of that, right? So I think when it comes to chemo and radiation, you really have to look at what has my cancer got going for it or not with those treatments, right? If it was me personally, I would still do all of the other natural stuff. Even if I had a 95% cure rate, I would do all the stuff I do to make me super healthy. I'll take the cure and I'll make me as healthy as possible. Now, if people say, which this happens a lot when you get to stage 4 cancer patients where you have metastases and the chemotherapy often is more kind of, let's slow it down if we can, the goals are different. If someone like that comes to me and says, I want to do, you fill in the blank therapy. We just talked about autologous immunotherapies. There are other types of therapies that might not be too available here in the US. Yes, I won't say who and where, but I either have consulted for and work with, or I partner with, not in a financial sense, but just I know them and I trust them, and I will tell a patient a lot of times, especially if they've got a little bit of time to make some decisions, look at these 2 facilities.
Yeah.
And one is going to maybe work better for you than another. Or if there's a particular therapy where I might have to go to a country like, say, Canada, I might know 2 or 3, depending on the location, and say, I want to meet with you and the people that run, and we'll figure out a way to get this done so that you can go do that. Now, and then if someone's going to Europe or some other place, then there are options. But yeah, it's, it, especially in the case of people where here, we see this all the time. The first line therapies slowed it down. Everyone thought they're going to go really well. Maybe there wasn't as much, adjunctive care to keep things going positive, or maybe it was just too aggressive and then it comes back.
Mm-hmm.
And the new standard of care in the US isn't going to do much.
Mm-hmm.
I would probably go and certainly check into, a modern immunotherapy of the kind we talked about.
Yeah. Awesome. Yeah. Well, thank you. This is incredible information, incredible support. If you could share with people how they can find out more about you, and then any last words, anything I forgot to ask about, anything you want to share.
Well, when it comes to cancer and chronic illness, we could talk for 40 days probably. So I think a couple of things. One is, for almost everybody I've ever met, there probably are more options open to you than you realize. So getting good information is number one. And obviously some apply to some people, some apply to others, but find out, because the more empowered you are as a patient, the better you're going to do anyway. So that's number one. Number two, there's a lot of things at the real, which we don't have time to get into, at the real core level, such as keeping your body moving, how you feed your body, all of those things, and then working on your mind-body connection, very important. Those are things you can do just with yourself and your own resources. And there are more and more practitioners out there who are better trained at what we've been talking about today, kind of and they may not do everything, but they might help you, kind of like the orchestra conductor, help you find the right resources to work on. And so I think, you probably have more going for you than you think. And it gets very scary when you go, to the hospital and they tell you, what they tell you, but just remember that's a piece of the pie. It's not the whole pie.
Well, and we haven't even touched on detox,
Right. All the
I mean, she had chemo off and on for 5 years.
right.
Um,
Yeah.
and it
Yeah.
was finally now in almost year 6 that she spent the last year doing more and more of the IV therapies, and, having, like I mentioned, we, went and did something a little bit more alternative where they took her own cell and made a dendritic cell vaccine. And she's been doing a lot of things that help her body detox, and now she feels great because a
Yeah.
lot of these toxins get built up and you feel really tired and you feel really sluggish and you feel really sore, and then once you start to release some of those, one of her favorites is the ozone IV. She says she feels like $1,000,000 after she does one of those. It's just very
Yeah.
interesting how we can kind of help our bodies pull some of that stuff back out again. So
Yeah.
anyway.
Just the process of being treated for cancer is generally very toxifying to your body. And, okay, so we had to do that. Doesn't mean we have to leave it all in there. Like, that's a huge part of, prevention and recovery. So yeah, there's just so many things depending on where you're at. As far as getting a hold of me, there's a hub website, which is easy to find. It's just DRANOW, dranow.com. And I have a very large and growing patient education YouTube channel where I record fairly short, bite-sized things on different topics, cancer, chronic illness focused. But also on there are resources of the books and things I've written and other stuff. So just dranow.com, and you can almost find anything about me you want there.
Awesome. Thank you so much, doctor. Really appreciate having you on.
Thank you.